Welcome, everyone. Thank you all for attending today. We value your time and invite you to invite your input throughout our session today. This is a Zoom meeting format, and you will be able to mute and unmute yourselves to ask questions or to share your insights. However, to avoid distractions as we hear from our presenters, we ask that you be on mute unless you are speaking, or if you prefer, you are welcome to enter your questions into our chat as well. So today we are here to talk about social determinants of health and technology's role in referrals and community connections. Here's our agenda. After a little bit of shuffling today, we will review health equity and social determinants of health. We will introduce technology used to address these issues. We will get to discuss Montana's Connect platform, and we will also hear from Unite Us and look at our larger regional and national initiatives as well. So my name is Deb Anderson. I'm a health information technology and quality improvement consultant with Mountain Pacific Quality Health. This is session number 2 of a 3-part series on social determinants of health, where we will discuss with you the use of technology to improve data sharing and communications among appropriate providers and community resources to support health and improve outcomes. In my 8 years at Mountain Pacific, I have assisted critical access hospitals and providers to select and implement electronic health records to meet meaningful use, program requirements, report electronic clinical quality measures to various programs, and now transition organizations to value-based care and the promoting interoperability programs with the Centers for Medicare and Medicaid. I am excited to support chronic disease prevention work across our region and continue to support health information exchange as a board member of both Big Sky Care Connect in Montana and Wyoming Frontier Information Health Information Exchanges. The title, Happy, Healthy, and Productive, comes from my personal mantra and a guideline for our children and grandchildren. We've been very fortunate during the public health emergency, but I know many who have not. My hope is that we can continue to discuss how to support happy, healthy, and productive in our families and communities, wherever that may be. Please help me welcome today's panelists. And first and foremost, I get to tell you that Julie is out sick today, but Kara Hughes is with us from the Montana Department of Health and Human Services. She is at the State Department within the Chronic Disease Prevention and Health Promotion Bureau. And that's an acronym I haven't heard before, CDP-HPB, as a program coordinator for the Connect program. Kara earned her Bachelor of Science in Health and Human Performance Health Promotion from Montana State University in Billings in 2013. She's been a certified location counselor, lactation. Let's get that one right. There's a little difference there. Since 2017, and has worked in public health for over 8 years. She is one of 2 State Connect coordinators working on the statewide expansion of the Connect referral system. She works with local health department staff to identify, train, and onboard community partners. Kara today gets to be our off-camera presenter. She is not set up technologically today from her home office to be able to share video, and that's just fine. As we know, we all have to accept the challenges that we get and keep moving forward. So we also have Jake Murphy, and Jake leads the sales for the Central Region within the Unite Us organization and has been with Unite Us for a year and a half. He's a veteran of the U.S. Army, where he served as an air defense officer for 7 years. Prior to his transition to the civilian sector, he graduated at the United States Military Academy at West Point, where he obtained a Bachelor's of Science in Systems Engineering and earned an MBA from Columbia University. And Lisa joins us from Wyoming. Lisa Almonds is a Unite Us Community Engagement Manager for the Unite Us Wyoming Network. Lisa has lived in Cheyenne, Wyoming all of her life. Prior to working with Unite Us, Lisa worked for a period at the state of Wyoming at a local nonprofit organization over the past 15 years to include Community Action of Laramie County, Inc., Prevention Management Organization of Wyoming, Cheyenne Laramie County Meth Initiative, the Wyoming Health Council, and even the Cheyenne Police Department. Lisa has a Bachelor's of Science in Health Science and is PMP certified, so project management professional. That's impressive. Thank you all for joining us. I appreciate your time that you'll be spending with us today as well. So let's get started with health equity. So if our goal is to improve health equity, let's make sure that we understand what this means. So health equity is when each person has the chance to reach his or her full health potential without facing obstacles from social position or other socially determined circumstances. That comes from the Centers for Disease Control, or the CDC. So it's easy to say, but I find it difficult to understand without a little visual aid. So this is one of the favorite slides I actually saw, and all of a sudden the light bulb went on that said, oh, so equality is when all things, the services, the education, and their interventions are exactly the same. But equity is when each person gets what they need to reach their full health potential. So hopefully, like me, you think a picture is worth 1,000 words, and now we get to understand a little bit more about health equity. So we also talk about the factors contributing to health disparities or health equity. And again, we'll be talking a lot about the social determinants of health, such as poverty, lack of education, racism, or community conditions. We know that medical services, especially in our rural and frontier areas, are an issue when we're looking for access to quality medical services. And then also what we learn through chronic disease prevention is that our behavioral factors, such as diet, tobacco use, engagement in physical activity, are major players as well in health. I recently saw a presentation that used this depiction, and I find it interesting because as I was studying the county health rankings, I was looking at, what do health outcomes really mean, and how do you determine the differences between, the length of life and the quality of life. So, we know that they're influenced by our healthy behaviors, the access to clinical quality care, and the social and economic factors, plus your physical environment. So again, one of the things that we really want to talk about is how technology can help with this, even though we know that clinical care is only 20% of what we're saying comes into the picture for the health outcome. So since I'm your resident IT geek, obviously I have to go through and tell you all about the different technologies that can support health equity. Obviously, the electronic health records contain data that help us manage population and population health and do analytics. So we're going to be talking a lot probably in our next session about the different types of data as well as the health of that data. But right now we're looking at real data, which is race, ethnicity, age, and language data. This you've been able to acquire in your electronic health records for many years because it was part of meaningful use. And SOGI, or sexual orientation gender identity data, also helps when we are looking for some of the health disparities, some of the information that we might need to improve patient-centered, patient-centric care for many of our other populations. And then obviously we've talked a little bit about the different assessment tools that can be utilized within the electronic health records. And again, we won't go into specifics in this session, but we'll be talking about that a little bit more in session number 3. Obviously, I would be remiss if I didn't talk about health information exchange and how we do need to make sure that as we are obtaining healthy data, we also have an ability to exchange that data with the appropriate providers, care teams, and community resources that we are working with to improve all of the care for our patients or persons within our communities. And then as far as expanding access, again, we can look at telehealth, and we all know that telehealth had an awesome increase, not because we wanted it to, but because a pandemic almost forced us to do more things remotely, and that includes some remote patient monitoring. We are working with some systems that allow our worried well patients to remain at home, but sending their vital information into their providers using equipment that can report directly into electronic health records or other clinician portals that they have access to review on a daily basis. And then, of course, for today, we're really going to be talking about community linkages and addressing our social needs. So the one thing I did want to make sure that everybody understands is that, technology is really not one size fits all. Not everyone uses the same EHR or the same functions or features from their health information exchanges, or even telehealth or remote patient monitoring in the same way. So today we get to compare and contrast a little bit with two major systems, one that we have being used in Montana, and this is called the Connect Electronic Referral System. So I would like to have Kara join us and present to us on the Connect Referral System.
Thanks, Deb. And can you hear me okay?
I can hear you perfectly. Thank you so much.
Thanks. And thank you all for having me here today. So as Deb mentioned, I am one of two Connect coordinators within the Chronic Disease Prevention and Health Promotion Bureau at the State Health Department, working on the statewide expansion of the system. More specifically, I work with local health departments that are getting partners on and services on, not only in their county, but their surrounding counties in their region. And I'll show you that here in a moment. But let's jump in and talk about what Connect is. So next, Connect is a system, it's a provider-to-provider referral tool, really, meant to close the loop in care coordination. Providers are able to work together in a more efficient manner to get the client information that they need and then track the outcomes of that referral within the system. So for example, provider A can refer a client or patient over to provider B or a community-based support or service and share the pertinent information about that individual. Then provider B or that service provider in the community can utilize the system to track the referral outcomes, what they suggest based on that referral, and provider A can get into the system and actually see what's gone on with the referral, how it's been updated, and kind of plans for next steps. Next. So as Deb mentioned, there's a lot of different referral tools out there and ways across the state that people are making referrals. So everything from your electronic health records to the health information exchange. But Connect is a platform that kind of is adaptable to all types of services and can also interface with a lot of other different programs. One second, sorry. So Connect really helps shift the current fragmented system that focuses on similar conditions and demographics to one that provides equitable access to care by meeting the client where they are and addressing the complex needs that may be underlying factors. So providers that are in the Connect system can work alongside the client to understand their needs and their motivations, and then make the referrals out that are most appropriate. And not only to medical services, but also those social supports or lifestyle change programs out in the community that really help the client long-term, such as food banks, housing, education, financial assistance, etc. Next. So some more basics about the system. It's a secure web-based system for sending, receiving, and tracking referral outcomes, as I just mentioned. And it's an interconnected statewide tool that allows providers to make a referral from their home community to anywhere across the state on behalf of a client. And then referrals can then be made back to a client's community for follow-up services and support. This is really key, especially with our rural nature of our state. We have quite a number of resources available at the fingertip of any provider that actually is in the system as a user. And it's accessible by any type of service provider. So as I just mentioned, it's not just meant for medical providers or medical services or services in the public health arena, but it's inclusive of everything from food banks to eligibility programs to again, medical providers, but also to community-based organizations like food banks. And it's scalable. So it works just as well for a independent LCPC who does everything, including sending referrals and intake forms, all of that, as it does to a larger organization such as a hospital with a lot more layers and a lot more of an elaborate referral process. And it's FERPA, HIPAA, 42 CFR, and IDEA compliant. It's been vetted not only at the local level, but at the state level. And as we make upgrades to the system or enhance the system, we continually work with our legal team to ensure that it remains compliant with these different privacy laws and statutes. And it's available at no cost. So unlike other referral platforms that may have a user fee associated with it, or maybe a group user fee, this system is free for any type of provider. So those community-based organizations to medical providers. And there is a number of different reports available in the system that show an organization areas where they can improve and areas maybe they're not doing so well. So it really shows different metrics of their outgoing and incoming referrals. Next. So where we are today, we've been working on the statewide expansion of this Connect system since 2019. And through the Chronic Disease Prevention Health Promotion Bureau, we've been able to hire a number of local coordinators, which I think has a lot to do with why we are so successful. So you can see right here, we've broken up the map into 14 health regions, and we have that hub and spoke model. So as I said, I work with the local health departments that are working on the expansion of the system. So in one of these counties, let's say Region 3, we work with Lewis and Clark Public Health, that main health department, to get partners and services on, but they also work not only in their county, but the surrounding county in that region, the surrounding counties in that region. And we have 12 regional coordinators at the health departments. And then we also have a partnership with the Addictive and Mental Disorders Division at the state health department, who have written Connect into a number of grants and have hired 17 different prevention specialists across the state that work in tandem with our regional coordinators, but they also focus on getting programs to address substance use and abuse, as well as mental health providers. So they're a little more focused in that way. And then we've also been able to hire 5 coordinators in higher ed. So a number of different colleges, including Stone Child and Rocky Boy, that also work alongside our regional coordinators and expand the system and get partners on. But they're really focused on getting schools and services for youth and their families on. Next. So unfortunately, as Deb said, Julie is not able to join today. So I'm going to touch base on what she's really found to be successful and kind of the wins she's had in her community, in her region, really. So she hosts monthly lunch and learns for about a half an hour where different agencies can jump on and she can really highlight what those agencies offer, you know, how they're really connected in their community and how to get in touch with them via Connect. It also allows for these agency staff to network amongst each other and kind of do some referral mapping where they can identify some other needed partners. She's also been able to include Connect in some local initiatives, such as the Mayor's Challenge, which is a challenge to reduce suicide among veterans, as well as the Early Childhood Home Visiting Task Force. Both of these plans included Connect in order to improve the referrals for their clients or their population that they serve and they're focused on. And then Connect is also a part of a number of the community health improvement plans, at least in 2 of the communities in Julie's region. So one really wrote Connect into their chip to improve the overall system and access to services. And the other county wrote it in really as more of like, this is an avenue to send all referrals for behavioral health services for after screening. So they screen their clients and then use Connect to get them to all of their needs to address social determinants of health. And she's had a lot of success, I will say, within St. Peter's Health, as well as Child and Family Services Division. Both use screening tools or work with the client to really make referrals internally, but also externally to get clients and families the services that they need. And Connects really helps streamline that referral process for those folks. Next. So within the state, we're also partnering with a number of larger organizations and have had a lot of success in doing so. So one, we are working with Big Sky Care Connect or Health Information Exchange in our state. We have a pretty strong partnership and we're hoping to continue to work together to have the two systems really hopefully complement each other and get Montanans really to where they need to be, whether it's for the purpose of medical referrals or out to social supports. We're also working with the Montana Primary Care Association, specifically trying to get resources on the system for cancer survivors. And then we've met with the Department of Labor and Industry a number of times. We're looking to get more of the job services on the system at the local level. And then, of course, we have a very strong partnership with the Office of Public Instruction. They've also provided funds for some of our coordinators, and they're helping us to get more and more of those school resources on and supports in the community for families. And we've also partnered with the state office, the state WIC office, excuse me, to get their WIC programs on across the state and just kind of streamline that and make sure that we're kind of, we have consistent messaging and that we're figuring out where Connect really fits in with their referral process. And lastly, we're partnering pretty heavily with a number of larger hospitals throughout Montana to get not only the chronic disease programs on, but also those partners of those programs. So we're looking at getting, our health coaches for hypertension classes on and getting their services on as well as their partners. Next. So Julie is also working on a couple of future plans and partnerships. One of them being really focusing on getting behavioral health providers. As many of you may be aware, there's really not a good system in Montana that one shows you all of the different counselors, therapists that are available, but also what their availability is, which Connect allows for that. A counselor can toggle on and off if they are taking new clients. And of course, you have all of those resources listed, whether you can focus on just your county or the whole entire state or telehealth. She's also working on getting more medical clinics and pharmacies on, really trying to ease the burden on some of the providers that work very closely with clients to manage their chronic disease. So for example, looking at pharmacies where if a client is dealing, maybe managing their diabetes, they may have a coach or a provider they work with on a regular basis, but they can also be referred out to the local pharmacies to kind of walk through medication adherence and next steps and plans for managing their health. And then she's also looking on expanding her lunch and learns. She's had one lunch and learn that included school counselors, and they were able to learn about the behavioral health resources, including Connect, but those resources in their community. And she's just focusing more and more on that. She's also going to be hosting a lunch and learn for not only providers, but the public for Suicide Prevention Month, which will focus on suicide prevention resources. Next. So one thing I want to talk about is just some of our system features that have made it pretty popular and pretty user-friendly for providers and public alike. We do have some unique signature options for clients or patients to sign off on a release of information in order to have a referral sent over. So we have electronic signature option, text message signature option, a link option, and then there's also a continuum of care provider option as well. And then, as I mentioned earlier, we have a number of reports that really show, really, I guess, demonstrate both what's going on with your outgoing and incoming referrals. And then we have a directory that's easily accessible to providers in order to find out what's exactly out there. So Deb, I'm not sure if we still have time for me to jump in the system to kind of show that.
I think we do. I'm ready to
Okay.
stop sharing if you're ready.
Okay, give me 1 minute.
Also, I love the fact that you were talking about health information exchange. Wyoming does not have a referral management system up and running statewide through our health information exchange, but it's definitely something that we've been working on, especially for chronic disease management programs as well. Are you able to share, Nan?
Yes, I just want to make sure that you guys are seeing the demo site. Am I correct? Just say connect demo.
Yes.
Okay, great. So once logged in, you can refer a client. I'll just show you that release of information piece. So I'm going to go ahead and click on an existing client. So the first thing before you send any referrals out to the community, they have to sign off on this release of information. It's going to auto-populate with their physical location. You can always clear that and either pick a county that they're moving to, or they want to look for services in that area, or you can select by the whole state. You can select by type of service you're looking for, insurance that that program or provider takes, and then special populations served. So if a provider serves LGBTQ or specific tribe or band, they can indicate that and we can find them through this. And then you can also filter by mile radius. So 5, 10, 20-mile radius, which is pretty important for individuals with that don't have transportation. So I'm just going to go ahead today and just type in mental health and select a few things. And based on that, the list has really shortened quite a bit, but I'm going to go ahead and select a couple of things to send Clark Kent to. I click next, and here's where Clark would actually sign off on the release of information. So you'd find demographic information right here. If he were under the age of 18 and had a parent or legal guardian who will be working with the provider to sign off on the release of information, you can indicate that here. Today we'll just say he's 18 and doesn't have a legal guardian. This language is basically saying that Clark Kent authorizes that the following information, or that his information could be shared with the following programs or agencies. And then for the purpose of this release of information, what type of information is he allowing to be shared with these programs? Today we'll just say medical and education and mental health. If it's not included on this list, you can indicate other, type in details. And then right here, who's actually working with the provider to sign off on the release of information. So this is what I was wanting to demonstrate. He's got a number of options. He can type in his name right here if he were to be sitting next to the provider. Click yes, I agree by checking here. Do you agree to electronically sign this document? He can sign by code. This has been pretty popular in times of COVID now. We've had a lot of individuals use this. So the provider would type in his phone number, send him a text message. Clark would then get a text message saying, this is for Clark Kent to sign off on a release of information. Reply yes if you wish to proceed, no if not. He replies yes. He then gets a 4-digit code sent to him that he can read over the phone to the provider. The provider can type in the 4-digit code and it counts as his electronic signature. We also have this review and sign feature where, again, the provider can type in his phone number or an email. He gets sent a link to this document and everything we selected, signs off on it, and then the provider gets an email saying Clark Kent has signed off on his release of information. You can now make referrals on his behalf. And then the last option is to upload a paper version of a release of information. So a lot of home visitors or different providers that maybe don't carry a laptop or have one available to them right then can actually bring this paper version to the client. They can fill it out, sign it, and then that provider can upload it at a later point in time. So I just wanted to show you guys those features. Here's where you can find the reports. So you can find like outcomes of all the referrals either sent into your organization or out of your organization. You have a number of different filter features, and then you can select by date. And here's where you can actually see, how many referrals were actually closed out. That individual actually received the services. Or maybe it was closed out, they were referred to another program. All of that within that time frame. And then even more specifics of where the referral was sent to and from where, who picked it up and assigned it to what provider, the day it was sent, when it was closed, and then what was the actual outcome. Was it closed because they were referred to another program, or closed successful completion? So we have, like I said, a number of reports available. And this really helps with quality improvement efforts and honing in on the referral process for that program or agency. And lastly, we have this directory feature. So even if you're set up in the system, so you're not necessarily getting referrals sent to you, but you're using the system to send referrals out, this is also available to you. So you can, again, filter by county that program or service is actually physically located in or offers services in that area, the type of service, insurance that program or service takes, and then population served. If you're looking for some programs that serve the Blackfeet tribe of the Blackfeet Reservation specifically, you can filter by that and those will show up. From there, you can also either type in, if you're looking for some service or provider specifically, you can search that way. But based on what we have right now, I'll just show you can click on anyone that shows up and you can see, who the main contact is, their location, phone number, and insurance that they take, and also services provided. This is the demo, so it's limited information, but usually this is quite detailed. So a provider knows exactly what that program offers before even deciding to send a client over there. So it really reduces on client overload and them having to be the sole navigator of resources and trying to sort through who offers what, and if they're taking any new clients. And so that's what's really great about the system. I'm going to go ahead and stop sharing my screen and pass it over to you, Deb. I'm not able to see the chat right now. I got to pull it up on a different screen, but does anyone have any questions? Okay.
Again, each of you can come off mute, or we'll take questions into the chat box. I actually have a couple for you. Well, first of all, Kara, I know you guys have been working on this for quite some time, and obviously it's very challenging. We do just now have a question from Anita in chat, and it says, what criteria are you using to determine success?
So we are using the number of individuals that are getting on the system on a monthly basis, referrals that are how the system's being used. We're looking at how many referrals were closed out, how many are open, how many people are enrolled in services, who all is using the system on a regular basis, where can we expand it? If we only see that, for the most part, mental health providers are using it, well, what else is going on? And that's what's so great about our local coordinators, because they are actively trying to work with existing partners in the system and partners outside of the system to fill in all of those gaps and really understanding what's going on and seeing the bigger picture in those reports. But yeah, I would say the biggest thing is just being able to see, how many people are on the system, who's using it, what are the outcomes, and what services are really being accessed, I would say. I hope that answers your question.
All right. I think it does. So we've got some amazing new questions here coming into chat. And one, I was actually going to have you reiterate that this is your system in Montana through DPHHS, but it says, does the program expand to those who may go to Montana for services from a different state? For example, kids who get seen from the northern part of Wyoming in Billings. That's a great question.
Absolutely. So we actually have a few programs in Washington and North Dakota on the system currently. I think because this is a grassroots initiative and it started at a local level, which I didn't really highlight in this presentation in particular, but it started just in the Helena area to serve youth in the school districts, and since has been expanded to other areas. And then in 2019, our bureau took it on, seeing what it really could do for the state in general, and started working on the statewide expansion. So we gave this system kind of a facelift, gave it a few upgrades, and then hired local support from across the state. But that being said, we're not just limiting it to Montana. I just think it's because we're just starting the growth of it. You just see more in Montana, but as long as that person or provider service is in the system, whether they're in Wyoming or Montana, they can utilize it.
Okay, and just so everybody knows, Kara and Julie's information is on the slide. Hopefully you guys can all see that when I share it again. Then we have another question from Melissa asking about your plan for ongoing funding for your coordinators.
Yeah, so we are working with a number of partners, even outside of the Department of Public Health and Human Services, to kind of help fund those positions long term. We also, with a number of our grants, there is a lot of surveillance in them. So within the CDC, those grants, they're funded long term, after a 5-year cycle or a couple of years as well. So, and this is a big part of that surveillance and gathering data in our state. But definitely looking of all different types of ways to fund those positions. The coordinators are also tasked with helping support their position and sustainability. So number of them are writing grants, and then they're all part-time positions. So really they're tied in with other jobs in their health department or wherever they're located. So they're part-time working on Connect, but part-time maybe as their CHIP coordinator or as their WIC coordinator as well. So those jobs, those FTEs are permanent.
Excellent. Again, I want to congratulate you on a lot of work done. And so it does look like we have one more question that just came in. It says, how does this function help with social service positions already at work, like social workers? And I was actually even thinking about like community health workers, which you may have in Montana, but we don't have in Wyoming.
Can you repeat the question one more time? Sorry, I didn't quite catch the first part.
That's okay. So, and it says, how does the function help with social services positions already at work, like a social worker? And, I can see a couple of different things, and maybe, Caitlin, if you want to come off mute, you could ask yourself, ask directly. But I'm thinking about, how, if you're in a social service position, how would this system, how would this information, how would this movement help you? And I can think of a lot of different answers.
Yeah, so I can kind of talk to that, but yeah, it might be helpful if she unmuted and if I'm not answering the question or not touching on the point she's asking. Oh, go ahead.
She said I got it correct. She said I got the question correct.
So
now we just have to work on the answer.
Nice job. So yeah, no, as a social worker, you would be a user of the system. So you would have access to all of those different resources, not only in your community, but across the state. You'd be able to refer a client that you're working with to any of those. So you may be meeting with a client for one sole purpose, maybe, I'm trying to think of an example, but we all realize that people show up at our doorstep with so many underlying factors and systemic issues. And that's where you can use Connect to refer out and track that referral. When so many other times, maybe you'll meet with a client and you want to refer them out to affordable housing in the area because that's something they're struggling with. Well, how are you sure, for one, that they're getting to that service and they're actually doing, that person's helping them navigate that? You oftentimes can't. You're handing that individual a card or a contact, they have to make outreach. But with Connect, if you're a user of it, you can send them over to that local program. Then it's up to that provider, as we call them, or really that user, to reach out to your client and make sure they're getting enrolled. And you're able to see all of that in the system. So that client's really getting all their complex needs met, and you're able to track it, and you know what's going on. I hope that answers your question. I think I understood it. And two, I will say there's a lot of providers that make referrals from where they're at to social workers. We have a lot of case managers in here that will use the system to do their case management work. So they may be also helping a client navigate resources, but they have this system to do so.
Excellent. Well, I think we've taken care of all the questions. So I'm going to go ahead and move us on. But Kara, thank you so much for your time and sharing that information with us. And hopefully everyone sees your contact information here. The slides and the recording will be sent out as well. And Maynette just posted the survey for us as well. So please remember to take our survey when it pops up for you at the end of our presentation. So a little more information next is, thinking about why we're actually talking about this and why are you hearing so much about social determinants of health and health equity right now. And personally, I believe it's because this pandemic has made it very clear that our families and communities continue to face challenges that will impact our lives for years to come. So there's a lot of national attention and momentum that we should harness for improvements across our region and be leaders in finding solutions for rural and frontier communities. Here's a few things on the slide, including the Congressional Caucus requesting information from each state on their social determinant of health barriers. I believe that information is due middle of September. I'm trying to assist with that in Wyoming, and I'm not sure, but there are probably others in other states coming up with the information and answering some of the questions that are out on the request for information. And then the National Alliance to Impact the Social Determinants of Health seeks to make a material improvement in the health of individuals and communities, and through multi-sector partnerships within the national system of health. So to advance holistic, value-based, person-centered healthcare that can successfully impact the social determinants of health. One of the things that Julie and I talk about quite frequently is, what are some of the pieces that are missing? And I've heard from neighboring organizations, neighboring states, health information exchanges, that when you're talking about rural and frontier communities, you're really talking about, a small group that you probably would get together to address some of the situations, but faith-based. So starting with your churches, starting with your schools, and starting with your healthcare organizations, is basically a good triad to start your foundation with. So hopefully, as we get into session number 3 and we start talking about taking action, some of that will come to light as well. So I know we had a few questions about the Gravity project, and the Gravity project started quite a while ago and addresses, as we acquire the information, are we able to share the information with the appropriate consents to different healthcare providers and organizations that are assisting with health and well-being throughout our communities. So this is a little technical, so hang on with me. The Gravity project seeks to identify coded data elements and associated value sets to represent social determinants of health data documented in our electronic health records across 4 clinical activities: screening, diagnosis, planning, and interventions. The project is focused on 3 specific social risk domains, which are food insecurity, housing instability and quality, and transportation access. These domains were selected based on both existing research linking these factors with health and utilization, on active experiments related to these domains, including federal, state, or local demonstration projects. The scope for phase 1 of Gravity includes the following activities and deliverables: to develop use cases that will serve to guide development of recommendations about documenting social determinants of health data in EHRs or related systems, identify common data elements and associated value sets to support the use cases, develop recommendations on how best to capture and group these data elements for interoperable electronic exchange and aggregation, and to initiate development of an HL7 Fast Health Interoperability Resource, or FHIR, implementation guide based on the defined use cases and associated data sets in order to set up our next phase, which was supposed to start in 2020. But with all of that said, here to tell us more about connecting health and social care and utilizing technology are Jake Murphy and Lisa Ammons from Unite Us.
Hey, thanks for that, Lisa. Or Deb, I'm sorry. Lisa, I'm glad you're on too. Yeah, hi everyone. My name is Jake Murphy. I represent Unite Us today. So I'm going to hit on a few slides that really talk about some of the work that we're doing at a more national level. So a little bit about Unite Us. We started back in 2013, really aimed at connecting kind of veterans or newly kind of titled veterans as they were exiting the military. So our two co-founders are military by trade, and they saw kind of in that transition process the need for care coordination to extend into kind of when you kind of create or go to that veteran title. You know, fast forward a few years and social determinants of health became a really big buzzword in the healthcare community. And, you know, we thought, hey, we're doing this in a microcosm of kind of this, the environment. We're doing this as it pertains to just this veteran population. How do we blow this out and do this across kind of, you know, all populations and do it for really everybody? That's kind of the work we're doing now. We will be kind of nationwide in all 3,006 counties across kind of our country in 2022. So we've had, you know, a tremendous amount of success. We have a bunch of statewide implementations and we will truly be national. But we're here to kind of learn a little bit more about, you know, kind of our approach on things. We truly believe, you know, that 80% of somebody's health and well-being happens in the community. You know, so as we're at this point of kind of having a conversation with an individual patient, a member, how do we extend that care coordination into the community? How do we connect with those community organizations? Next slide, Deb. Perfect. And the way we view this is really kind of creating this mesh to, you know, to exist between health, human, and social service organizations. So as you saw kind of in the previous demo, you know, there is an instance of technology that can be helpful in coordinating this care. You know, we have a standalone environment that's really standalone web-based kind of environment that's really helpful for a community organization who maybe doesn't have sophisticated software to really use to kind of adopt and kind of be able to then, you know, accept referrals from healthcare governmental partners. But we also have an instance of our platform, which, you know, facilitates referrals kind of across this continuum that embeds into EMRs and EHRs, that embeds into care management solutions and HMIS systems and all of that. We'll get into it later, but we truly believe that we need to meet these organizations where they need us to meet them in order to kind of facilitate not only questions and whatnot being asked, but those referrals to go to the community. We don't want to deviate away from workflows. We really want to kind of embed ourselves within those existing workflows, all under kind of the goal of really providing that wraparound care around an individual, getting them connected to the appropriate service provider or community organization kind of in their community. Next slide, then. A little bit and a little bit about how we do things. You know, there are other solutions out there kind of in a national that have national presence that really find, you know, value in just kind of creating a resource directory or cultivating those local resources. You know, we have a component of that in our technology at Unite Us, but we truly believe, and next slide, Deb, in creating kind of accountability within these networks. So at this point, I want to pass it over to my colleague, Lisa, who's going to talk a little bit about the role of a community engagement manager, a position that we have over 300 plus at Unite Us. that are scattered across the country. So go ahead, Lisa.
Hi, thanks, Jake. My name is Lisa Ammons. I'm a community engagement manager, as Jake said. My colleague and I, Avery Bedford, we work for the state of Wyoming, and we work with nonprofit organizations and safety net organizations to educate them about Unitas and bring them on board to the coordinated care network. Take a drink of Kool-Aid real quick. With my whistle. Okay, so I wanted to share with you a little bit of information about the participants who are here today on this webinar, to include Montana, Hawaii, and Wyoming. So with Montana, we've currently got 21 organizations on the network. Services include benefits navigation, employment, education, housing and shelter, and substance use. Our waves for Montana, because we go in waves, because we go across the state completely and connect the network. So with the waves in Montana, we've got Billings Metro is currently live and in 13 counties. Missoula Metro will go live in October of this year. Great Falls will go live in March of 2022, and the rural counties of Montana will go live in September of 2022. So we've got between about probably 2 to maybe up to 3 or 4 community engagement managers per state. And Keely McCabe is the senior community engagement manager for the state of Montana, and she has 2 additional community engagement managers. And so at the end of the webinar, if anybody wants to reach out for any reason to Keely, Deb could get you that information. Hawaii for this webinar is another state that's participating on this webinar. And we have 66 organizations on the network. Again, benefits within this network include, services include benefits navigation, food assistance, mental health and substance use, housing and shelter, education, employment, transportation, and legal services. The WAVE schedule for Hawaii is Honolulu County is currently live. And then Kauai, Maui, and Hawaii counties all go live October 19th of this year. Carol Hoishida, she is the community engagement manager. And there is an additional CEM in that state as well. And again, we can get you that information if you're interested in contacting Carol. And again, Avery Bedford and I, and we're the Wyoming CEMs. And we have currently 26 organizations on the network. And so we went live with our first set of counties, which includes Albany, Laramie, and Natrona County in the state. And major services that are provided in the network are legal, education, food assistance, mental health, substance use, housing and shelter, and utilities. So for our waves, we've completed the one, and then we've got a final wave. And so that includes the remainder of the counties across the state. And so that final wave will go live on November 16th of this year. And so again, myself and Avery Bedford, we're the contacts for community engagement for the state of Wyoming. And that's my updates if anybody had any questions. Or we could save them for the end. And I'll pass it back to Jake. Thank you.
So part of, and if you didn't gather this, part of the work that we do is really engaging the community. So again, a staff of over 300 folks that really are embedded in the local communities, socializing this notion of kind of extension of care coordination. We provide our solution at no cost to community organization. There is a cost for kind of what we deem healthcare, but that really drives sustainability in our model. Also, states usually can fund this, as well as paying entities. But for the community, it is a no-cost solution. And the only thing we ask for kind of in return is for them to keep up information up to date, to respond to referrals within kind of a time, like a agreeable time frame, And, if they can provide that, that service, if not, they have functionality to reject the referrals or send it elsewhere, a full kind of array of options for them to choose from or to utilize. Next slide, please, Deb. This just gives you a sense of kind of the referral pathway and how it exists and who all can touch it. This is just a small sample. We have schools in certain networks that are using this. We have emergency departments, of course, community health workers, a lot, social workers, community orgs, you name it. They can all access kind of a single instance of Unite Us to make referrals, send those referrals to the appropriate agency within their communities, and then have the visibility kind of that goes along with that. Referrals will be accepted by organizations, and that is presented back to that referring entity. Once referrals are accepted, they become cases, and cases can be resolved with notes and outcomes, and you can have that visibility on where those needs addressed or not. And then hopefully, over time, we're starting to see kind of impacts to health holistically. Next slide, please, Deb. I'm going to hit a few more. I'm going to go quick just because we're running out of time. HIPAA, FERPA, FIPS, Part 2 compliant. We do take compliance kind of top of mind. We recently got our high trust certification as well. So we just want to make sure that data is secure and available to those organizations that are participating in the network. We have a stance that it is their data. They are kind of, sharing kind of referrals, but that is the data between that organization and the referred to entity. Next slide. This should kind of just provide a quick example. Very similar to the last presentation. We do need consent from the individual, informed consent. We have 6 ways to gain consent. We can send text message, email, on screen, paper upload, audio upload, and we also have, in the days of telehealth, user attestation. So meaning a script can be read to an individual, and that individual who's read the script can sign on behalf of the individual. You can see here that referrals can go from this housing provider to a number of different agencies. We do have kind of what we call sensitive organizations, which is denoted by this lock, where information shared to that individual organization would be mass from view from everybody participating. It wouldn't be, transportation wouldn't be able to kind of view that referral and back and forth that happened with a mental health provider and whatnot. Next slide, please, Deb. And then I'll start to get to questions. Where are we going with this? I think this is kind of the most appropriate slide on this. Is we're moving from kind of beyond a resource directory to establishing this operating system that sits across, health, human, and social service organizations. You can see that providing community and analytics and data around where social needs are being addressed, where are maybe certain communities falling a bit short, and taking that information up to various funders to maybe kind of put more money and pump more money into the system. We have a large push to kind of go into value-based models, and how can we start compensating these social serving organizations, the community organizations, for the work that they're doing. We'll have at Unite Us, we'll have a payments product that will be released next year that will help facilitate funding to those community organizations. And that's the why these community organizations are kind of participating. Overall, we want to get to major systems transformation. How do we flip the script? How do we invest more in social care holistically? All under this foundation of interoperability. How do we meet people where they're at? How do we meet organizations where they're at? So I know that was quick, rapid fire. Deb, thanks for the opportunity. Questions?
So right now in chat, I've got a request for copies of the slides, which of course we'll send out. And then at some point, they're asking about, from both of the groups, but we won't have time today. Maybe this is something we can address on session number 3, how to overcome the challenges in rural communities who won't have access to tech that would be able to utilize these platforms. And I definitely have some ideas on that one. But since we are right at time, I'm going to go through the last few slides here really, really quickly. We do have an opportunity, and again, you'll find this in the slide. If any of you are interested in joining a Mountain Pacific affinity group that will be talking about increasing patient engagement through the community partnerships, That link will be here on slide number 29. Those of you who have already registered don't have to register again. However, our third final session on social determinants will be September 12th at 1 p.m. Mountain Daylight Time. We hope that you will all join us. And if you have recommendations or questions that you would like for us to address, please be sure and put that into the evaluation forms. We've shared this slide before, but here's some of the national tools that have been created for getting information about social determinants of health. And I believe both of the platforms that we looked at today are able to utilize those assessments as well. And then, you know, the big thing that we keep saying is it is a big nut to crack. You can start small. Next session, we're going to talk about taking action. And so you might want to say, what can your organization handle right now? And, you know, what is within your power to address? But we do think it's going to be important to get started someplace. And we hope to help encourage you with our final session and our affinity group to start taking action. Here's the link to the resources. That Action Center I've been looking at and studying it myself. It's got some great information in it. So I encourage all of you to take a look if you get a chance before our next session. And then obviously, thank you. Please complete our evaluation. And here is my contact information. If you would like to get in touch with any of our presenters and you missed their contact information, I'm happy to share it with you at any time. And with that, I do not see any additional questions. I encourage all of you to join us again for session number 3 September. And it's been wonderful having you here. Thank you for all you do. Thank you for spending your time with us today. Have a wonderful day.